Alright, now let's talk about the things that can go wrong with lipids and lipoproteins. A standard lipid profile measures the LDL, the HDL, the total cholesterol, as well as triglycerides. A dyslipidemia is any significant difference from normal values in the lipid profile. High LDL as well as low HDL are both well-established risk factors for atherosclerosis as well as coronary artery disease. And before we move on, it's critical that you understand these lipid particles. And do you remember which is the good cholesterol and which is the bad cholesterol? Well, hopefully you remember that high HDL is protective because it moves cholesterol from the body into the liver to be excreted as bile salts. And high LDL is bad because it may lead to atherosclerosis. Alright, now let's cover the different dyslipidemias. Type 1 dyslipidemia, also known as hyperchylomicronemia, is defined as an increased chylomicron level. This also results in elevated levels of triglycerides as well as cholesterol in the blood, although it mostly affects the triglycerides. Now, hyperchylomicronemia is caused by an autosomal recessive deficiency in lipoprotein lipase, or by a defective ApoC2, which is the cofactor needed for lipoprotein lipase. And physiologically, this makes sense, as lipoprotein lipase is activated by ApoC2, which leads to degradation of circulating triglycerides, which are found in chylomicrons, and these are converted into fatty acids, which are stored in adipocytes and muscle cells. And with all that, how do you think hyperchylomicronemia presents clinically? There you go, it can present as pancreatitis, hepatosplenomegaly, as well as xanthomas. And you can see an example of xanthomas here. It's important to note that hyperchylomicronemia does not increase your risk for atherosclerosis, since there isn't an elevated LDL. Now next up, we have type 2 dyslipidemia, which is also known as familial hypercholesterolemia, and it's characterized by an increased LDL and cholesterol levels. Now it's caused by an autosomal dominant mutation that results in an absent or defective LDL receptor, or a defective ApoB100 lipoprotein. Now, if LDL receptors are absent, or they're not working, or if ApoB100 is defective, and it can't bind to the tissue LDL receptor, this results in the same pathology, which is the LDL can't be taken up into tissue, and therefore it accumulates in the bloodstream and eventually becomes deposited within the walls of vessels. Now, the LDL molecule carries cholesterol to the body, so cholesterol is going to be increased as well. And this leads to atherosclerosis and vessel injury, which you can see in the picture here. It can also cause corneal arcus, which is the pale arc of cholesterol you can see in these images. Now this is very similar to arcus senilis, but it's seen in much younger folks. Now these deposits are generally benign, and they can be seen at the top and bottom of the iris, and they will fill in until they cover the whole circumference. Now the last image I want to show you here is of tendon xanthomas, and here are a few good examples. Now there are a few other things we need to talk about before we wrap up familial hypercholesterolemia. The first thing here is that there are two types of familial hypercholesterolemia, type 2A and 2B. The only real difference here is that type 2B has increased levels of VLDL, as well as LDL and cholesterol. Another important association to remember is that you can have a heterozygous as well as a homozygous form of this disease. Now the heterozygous form is fairly common, and it's seen in about 1 in 500 people and presents with a total cholesterol level around 300. And the homozygous form is quite rare, and it shows up with total cholesterol levels around 700. So how might this show up on your exam? Well, if you're given a patient with an increased LDL, as well as cholesterol and VLDL, and they have a total cholesterol level of 785, which type of familial hypercholesterolemia might they have? Great, they would be homozygous for type 2B familial hypercholesterolemia. Now next up, we have type 3 dyslipidemia, or dys-beta lipoproteinemia, and this is an autosomal recessive disorder that's due to a defective ApoE protein. And do you remember the function of ApoE? There you go, it participates in remnant uptake by the liver, and it can aid in uptake of every lipid particle except LDL, but is most notably involved in chylomicron and VLDL uptake, as you can see here. So with all that, what do you think we'll find will be elevated in the blood? There you go, predominantly VLDL and chylomicrons. Now this type of familial dyslipidemia also increases your risk of atherosclerotic disease, as well as it leads to the development of tubo-eruptive as well as palmar xanthomas. And you can see a few examples of the tubo-eruptive xanthomas here. Now last but not least, we have type 4 dyslipidemia, or hypertriglyceridemia, and this is an autosomal dominant disorder that is characterized by high hepatic production of VLDL molecules. And do you happen to remember what VLDL molecules are primarily made of? There you go. VLDL contains mostly triglycerides, so you'll see increased triglycerides on the lipid profile. Now this most notably causes acute episodes of pancreatitis, just like we saw in type 1 dyslipidemia. And can you think of a disease that may be associated with type 4 hypertriglyceridemia? There you go, type 2 diabetes, as hypertriglyceridemia is often seen in the setting of insulin resistance. Alright, well that'll wrap up the familial dyslipidemias. See you in the next video.